Okay, well, thank you, Deanna, and thank you to the organization for having me here. I acknowledge everybody in this place that it's an honor to be here, and that I'm on this journey with you as well. As Deanna said, I'm a neurosurgeon, so if you like to read more about the surgery, you can read this book up here. It's about 1,000 pages. But if you want to know more about me as a surgeon, you can read this one in the bottom, which is only about 120. So I do surgery for this condition, but also gamma knife surgery, which is a form of radiation, and I'll talk to you about tomorrow. And dates back a long time. This is the 30th anniversary of the first operation we did that way. And this is a book one of your members wrote. Her son has gigantism. It's not quite as long as my textbook, but it's a little longer than the novel. And it's a story of basically, I think, her journey and her son's journey and the love between the two of them. So that's a nice book to read, and I think you will see a lot of commonalities with your own journeys and hers. So when Deanna asked me to talk, we had a number of things we were going to talk about, and she said people want to know about surgery and who's a good candidate for surgery. Do I need surgery? How do you choose who's going to have surgery? And the second thing she said is people want to know how the surgery is performed, and then what can I expect from surgery, both in terms of what the outcomes of the surgery would be, but also undesirable outcomes, so they can weigh the benefits and the risks for their particular situation. So if there's other questions that you have, I'm certainly available at the break or any time. If you grab me and ask me questions, I'm happy to answer, and I'm here for you this weekend. So this complicated slide is a slide from the Endocrine Society, which is one of the international society that doctors and healthcare professionals get together every few years and make guidelines which are to direct healthcare professionals around the world. And you can see right up at the top, surgery plays a prominent role, and in the bracket they put most patients. So I would add in the right center and in the right team's hands, almost everybody should be considered for surgery first. So what are the indications? First of all, we work very, very closely with our endocrinology colleagues, our neuroradiology colleagues, our ENT colleagues, and many others to make sure that the person has an actual diagnosis of acromegaly. This is very, very important. Dr. Izat, who's a leading international figure in acromegaly, also from Toronto, will talk about that diagnosis, I think, tomorrow. And this is very important. It's based on a proper history. Doctor has to listen to you and hear your story, has to do a physical exam, which I think also should include a physical exam dating back many years. And often if you go to the doctor, bring some old pictures. That's very helpful. Biochemical, that's the blood tests, and the imaging, which is the MRI and CT. Secondly, the person has to be fit to have surgery. This disease affects the heart, as many of you know, and the lungs. And if the person's heart is too weak to have surgery, the risk of surgery increases, and that person should be managed medically, at least to get things stable first. And then thirdly, the tumor has to be accessed. We should be able to get to it safely, and that involves a detailed review of the MRI. So we can't really say, am I a good candidate for surgery without seeing an MRI? So the surgeon has to look at that to together with the neuroradiologist. And of course, we need a person who is informed about the condition, who can weigh the risks and benefits. So that's informed consent. So the patient should be understanding what the goals of surgery are, what we can achieve with surgery. And these goals are, first of all, to diagnose the type of tumor, because there are a series of different kinds of tumors that can give the same appearance. And so when we look at the biopsies taken at surgery, we can tell. The pathologist tells us the kind of tumor. The two big ones that you'll hear are sparsely granulated and densely granulated. And those are important because they have very different responses to medical therapy if you need to have medicine after the surgery. So one main thing is to make a diagnosis. That's very, very important. And we're getting closer to making the diagnosis without surgery, but we're still, it's still not good enough in terms of making that diagnosis. And as we move into the genetic era in medicine and personalized medicine, I think it's going to be even more important to have proper tissue so we can study the tumor and classify it even more carefully so we can get personalized treatments in the future and hopefully not need surgery. So the second reason we do surgery is to reduce the effects of the excessive growth hormone which these tumors produce, and it causes all the internal organs to get big and also our external appearance to change, but also the cognitive and neuropsychological effects such as depression. And then finally, if the tumor's big, which some of them are, and they're causing pressure effects like bad headache and vision disturbances, then we want to remove the tumor from those areas. And then finally, we want to try to get rid of it all if we can and avoid the need for very expensive medications. The medications, as many of you know, cost thousands of dollars a month. And many of us are fortunate in Canada to have the social support system that we have. But we're extremely lucky. Just south of the border, many people cannot have it because of the expense. So if we can do good surgery, there's always a place for good, effective surgery. And even if we can't get all the tumor out, we can often reduce the amount of medicine that people need to have. So that's why the Endocrine Society puts surgery right up at the top. And that's critical. So the second question Deanna said is, well, how do we perform it? Lots of people have questions. There's lots of words that are complicated, like transsphenoidal, craniotomy, all these words. So can you explain a little bit about that? Well, here's where the tumor is. It's pretty much, if you had anywhere to go, it's almost right in the center of our head. So traditionally it was a difficult spot to get to. And the first operations in this area occurred only in the late 1800s. And they were all opening the head and getting to that area. And then around the turn of the century, people started to go and attempt through the nose. So they're going from above is called the craniotomy, where we open part of the skull. So imagine your eyebrows and anything above where we open there. But we would have to go underneath the brain to get to this area. The transsphenoidal is basically through the nose. One of the sinuses that we have around our nose is called the sphenoid sinus. And transportation or transsphenoidal, that means we go through the sphenoid sinus. So that's why it's called transsphenoidal. So one is going from below and the other is going from above. We haven't had to do a craniotomy for many years since we developed this. So in terms of transsphenoidal, there are two main kinds of transsphenoidal. So in the early 1960s, a colleague of mine named Jules Hardy who was from Montreal, actually. So there's a rich Canadian history in this surgery. He learned from a gentleman named Guyot, who was a French surgeon, to do the surgery here, but they had no microscope. And at the time in the early 60s, one of the neurosurgeons from California, Ted Kersey, introduced the use of the microscope into neurosurgery. And Jules Hardy incorporated that and was the first to use the microscope to access this area. And our progression was to use the endoscope, which is a telescope we put right into the nose and right up into the sphenoid sinus, and we use both sides of the nose, not just one. And that was published in 1996, but we did the first surgery in 1993, and you can see here we're using both sides of the nose, and we're looking, it's an early picture, we're looking at the television where we're operating. Here's my surgical team, and we have things like a GPS system here that are guiding us. And it was a total change in the way that we were thinking about surgery and doing surgery. To me, it was this minor change, but it's incredible how it has transformed what we do. So traditionally, we were looking into a microscope operating, and then we shifted to the endoscope. And the first patient was an older gentleman who had developed double vision and a droopy eyelid, and had a pituitary tumor that was extending to that region. And I thought he actually had a spread of cancer to that area. So I went to my ENT colleague, Dr. Fenton. At the time, he had done about 2,000 or 3,000 operations on the nose, and I said, look, I think this gentleman has cancer. I just need to get to do the sphenoid, and can you get me there so we can biopsy this gentleman and get him radiation? He said, yeah, I can get you there. And so that was the first case we did. And it was a little bit disorienting to me because normally brain surgeons stand, if you could imagine, an operating bed here in front of me. Person's head hangs over the top of the bed. The neurosurgeon stands at the top of the bed, so we're basically looking upside down. Whereas the ENT surgeons would stand this way. So it was upside down for me the first time. So I had to change in my brain how I was looking at things. So it was a bit disorienting. By the second one, I had gotten the hang of it. And so a lot of surgeons found that very disorienting. So it took about 10 years for this operation to catch on. There were early adopters like anything, but it took about 10 years. And the other big thing with the microscopic, it's usually a one-person operation and 2 hands through 1 nostril. So I said to do more things, we need to be able to hold things and change things. We need to be able to use both hands. So the way we make a small opening at the back of the nose, I'll show you a video, I hope it works on the Mac, how we do that. So these were some of the major changes, and all of a sudden it opened up the view from us just looking at one table, because we're putting the scope right in. Now we can see the whole room. So if the tumor is growing off to the side, now we can see off to the side because we also have telescopes that have angled mirrors, and we can look off to the side. And if we have angled instruments, we could be standing looking at Deanna and Jill's table and Heather's table, but actually the view is looking over at this table. And if the tumor is growing over there, we can get it with this, but with the microscope, which looks straight ahead, we could only get that. Okay, so we did some studies very early, and we showed for the ones that are straight ahead, good surgeon was good in both ways. And some of my colleagues are fantastic surgeons, and they use the microscope still and do fantastic work. But still, to get off to the side, the endoscope's helpful. So many of those surgeons have added the scope or get somebody in to help with that. So here's a little video. This is a video that one of my students did. So I hope it works for us. It's an animation. There's no blood, there's no redness, because often I can't understand those red bloody videos either. So I said, let's do something that people can understand. So the first section talks about the anatomy, where the cavernous sinus is, the blood vessels, the nerves, why the surgeons have to be careful there. Then we go to what we call the nasal phase, which is working through the nose, which we do routinely with a nose specialist. And then we call the sphenoid phase, where we're getting in there, and then the tumor. And this particular one is kind of, I wanted them to change it a little bit, but it's good enough for schematics and to understand things. And if you want to look at it in more detail, you can just Google their Vimeo, that's a video website, and transsphenoidal. And the student's name was Ryan Kissinger, who's a very talented artist who I think works in Virginia now. And he's done some fantastic work. So let's see if this will work. If I can get it going. Oh. That's what I was worried about, going from Mac to, PC to Mac.
Was that video embedded in your USB drive and not as part of the presentation?
It's in the presentation.
Okay.
I can pull it up on my computer and.
We also have Wi-Fi on that computer if you want to go to Google.
Yeah, I'm not a Mac guy, so someone who's a Mac person can come and Google it if you want. It's in 4 1-minute videos online because 1 minute is about anyone, including surgeons' attention span. So we put 1-minute videos, not 45-minute videos of red stuff that you can't understand.
Maybe we can play them at the break then.
Yeah.
We'll go to Google and do that.
Yeah, okay. Anyway, I'm sorry about that.
I'll see if I can.
Yeah, see, you got the Ryan Kissinger and Vimeo and transsphenoidal? Okay. So anyway, I was going to show you this animation. You can bring it up on your phone as well. And I think it explains things nicely, but it also explains what we might expect based on the person's particular tumor configuration and where it's growing. So what can I expect? So the first thing many people are worried about is surgery is dangerous. And that's why I say it has to be in the right hands, in the right place, with the right team. So let me talk about those first. So we can think of these issues, first of all, first and foremost, problems that could occur with the nose. If we were having an operation on our tummy or on our leg, we would cut the skin on the tummy or your leg, and you would have pain from that, or you would have swelling around the incision. So we cut inside the nose. There's no cuts on the outside. So it's not surprising that we have symptoms related to the nose. Then we think of the problems that could be related to the brain and the pituitary gland itself and the vessels and different things around there. And then the rest of the body, like a general anesthetic. And that's why I say we need to assess the patient. Our anesthesia colleagues are critical to assessing the patient, to look at those other things. And then about the other thing is what's going to happen to my acromegaly. So I'll get to that next. Did we find it?
Yeah.
Did you find all 4 of them there?
Well, I just typed in what you had on.
Yeah. Yeah. Garnett, do you want to do it now or at the end, or
I think it'd be smoother to do it at the end.
whatever you guys want?
I think at the end would be really good, just leave it there though.
Just check if the other four are there too. Because the first one is just about the anatomy. Okay, so what about the nose? As I said, the blockage of the nose is probably the commonest thing that people talk about when they come back. Mucus buildup. Due to scar tissue, we routinely leave 2 plastic sheets in the nose for a week or 2 and then take them out because they've been shown to reduce scar tissue and all these symptoms of blockage and mucus. But I can tell you still, it's uncomfortable. If the nose doesn't clean itself out spontaneously, and when you cut the lining of the nose, it loses that conveyor belt function to get all the snot and mucus out of your nose, it tends to back up. If you don't wash it out very well with salt water, then it'll back up, get stagnant, and you'll get an infection called sinusitis. You'll get yellow, and if it's really bad, it'll turn green, and everyone around you will tell you smell too bad. So that's a sign that you need antibiotics and go and see your nose specialist to get it cleaned out. Nosebleeds can occur because we're making cuts there, so we usually advise people not to blow their nose. Some of the nosebleeds can be very serious if we've worked around the cavernous sinus. So listen to your surgeon. And not unsurprisingly, if the nose is plugged, smell is going to get affected, and about 80% of taste is related to smell. A very small number of those can be permanent, depending on the extent of the surgery that's been required, but we did research looking at smell, and by 4 months, everybody who had it before got it back. So those I think are the big symptoms. Many people call them a nuisance, but they do affect your quality of life initially. But the good news is that you get over those and things generally come back the way they were. And some people who had polyps and septal deviation sometimes actually get better because you've gotten a septoplasty or a polypectomy at the same time as the nose surgery. So let's move on to the brain, which are the serious problems, but fortunately much rarer. And I think the one that is the most reported, and I've just given a bunch of lectures for the 30th anniversary of this operation all over the place, and I spend most of the time when I talk to surgeons about preventing blood vessel injuries, because if a surgeon hits a blood vessel, it usually means a stroke or death, and nobody's going to report their strokes or death publicly. Nobody wants, thanks Joe, nobody wants that, but that is a reality. Now if you look at the face here, and I'm sorry the video didn't work, but it would show how we open here. And imagine if we have our face like this and we open a book, cut through the middle, we would see right at the back something like this. And this is the pituitary gland here that is sitting under the optic chiasm, which are the nerves that help us to see. And on either side is the cavernous sinus, where we have these big blood vessels called the carotid arteries that bring blood to that half of the brain. And then in the wall and in the center of this are the nerves that move your eyes and also give feeling to your face. And so we want to avoid hurting these arteries. There are also arteries up here that these branch, and there's arteries up here, and there's very tiny arteries that you can't see on any MRI, but the surgeons should be able to see them if the tumor is small enough, that are critically important to vision and other structures in that area. So this occurs and even in the best of hands, and it can happen even if we don't hit it due to an infection that sets in, or other problems like the tumor or an aneurysm. So we routinely look at the blood vessels very carefully. Patients with acromegaly have a higher incidence of brain aneurysm, and the anatomy, like how thick this bone is, can vary tremendously. And most acromegalics have thicker bone as well. And the acromegalic tumor grows downward more frequently than other tumors and can grow into this area, and is the reason why surgery sometimes needs to be added to with medical therapy. We need the medical therapy. So those blood vessel problems are extremely rare but can be very devastating. The pituitary gland, the tumor, imagine a little tiny tumor here starting in the pituitary gland, and over the years it just keeps getting bigger and bigger and bigger and bigger. It's going to squish the normal pituitary gland off to the side. So the surgeon's task is to dissect or to separate the tumor from the normal gland without damaging it. And that normal gland can be down to paper thin. And so the surgeon has to identify it and then preserve it. And that can, if we don't, then we can require hormone replacement, like cortisol or DDAVP after it. Now just above here in black is the water that surrounds the brain called the CSF. All of our brains float in water, and this lining is very thin, like a spider's web, and we call it the arachnoid. And if we break through that, the fluid from the brain will drip down into the nose, and that gives a passageway for the germs in the nose, which naturally sit there, to go up into the brain, and we can get meningitis. So if there's a leakage, like a faucet dripping post-surgery, you better let your surgeon know and go get into the hospital right away, because the germs can get up there and cause meningitis, and that can be very serious or fatal. Now, the other thing that I mentioned is that the nerves to the eyes that see, and these nerves that move the eyes, they can also get affected, so could lose vision or get double vision. Again, those are extremely rare because usually there's the lining between it. I've talked, I think, mostly about that. So, so how often do they occur? This is some results from Systematic Review, which is a collection of studies, and some of our own experience from about 15 years ago. I haven't reviewed our cases and published them recently, but I can tell you our leak rate is around 2%. But in the literature, the average was about 17%, and it persisted in 2% of the patient needing surgery after. So usually the surgeon sees it in the surgery in 17% and plugs the hole. Usually they plug it either with some glue or take a little piece of fat from your leg or your tummy and then plug the hole. Diabetes insipidus refers to the lack of one of the water hormones that keeps water in your body, and when you're lacking that hormone, you constantly have to pee. And you're constantly thirsty, and that's called diabetes insipidus, which is different than diabetes mellitus, which is sugar diabetes. Okay? And then other hormones, about 6% of cases. So imagine I told you that the gland is very, very thinned out. Now, it doesn't mean that it's all bad. This is some work from one of our former fellows, John Jane Jr., who's I think in Virginia now, and they showed, and our data is similar, that you can actually get return of function, and the commonest hormones that return are the sex hormone functions, but even the adrenal function, which is the cortisol or stress hormone, can return. So good teams can get actual improvement in those other hormones which can be lacking prior to surgery. And that can occur in a third to a half of patients if we're able to preserve that gland. And again, it depends on the care and attention and the experience of the team. That's really critical to getting that back. So then what about the acromegaly? I'm going to have the surgery for the acromegaly. What's my chance of getting cured from the surgery? And I told you it all depends on the kind of tumor and where that tumor is growing, and also the biology of that tumor to give that answer. So sometimes we don't honestly know the answer, because I told you there are about 8 or 10 different kinds of tumors that lead to the appearance of acromegaly. And some of them are quite aggressive in that no matter what you do, they keep coming back, and other ones are more relaxed and they don't come back if you take them out. So we don't know for sure until time will pass. But if we just look at the appearance on an MRI, tumors that are less than 1 centimeter are called microadenomas, and tumors that are bigger than 1 centimeter, or about 1/3 of an inch for any Americans or Canadians who haven't switched over, that's called a macroadenoma. And the results are better if you have a micro. Makes sense that the smaller it is, the more likely. And so the results vary, and you can see there the range varies from 63 to 100% for the micros, but the macros, not as good, from about half to 3/4 of people. Now that's still pretty good. If we can avoid medical therapy in 3/4 of people, it's pretty good. Imagine not needing the medication constantly for the rest of your life. Now, it's important to know which criteria were used to state cure, because it's a moving target. The surgeons are held to a greater and greater standard every time the Endocrine Society looks at the guidelines. So it's important to understand those criteria, and the medical criteria are to normalize the IGF-1, which is one of the hormones that are measured, and I think one of the endocrinologists will talk more about that. And really, this has gone down now, so we have even a tougher standard, down to preferably under 0.4 and ideally under 0.2. And if we do the glucose suppression test, we want to see it going. And most important for the person going through things and their family and friends is that they feel better. The symptoms are better. So here's a systematic review again. In this particular series, they had looked at 820 patients, and the resection of the tumor was quite high, about 3/4, and the growth hormone secretion rate was even better, even though they didn't get all the tumor. It's like they cut the blood supply to the remaining tumor, and they actually improved. And this is what I was saying earlier, that the results really depend on people's things like age, because when we look at, and at least in our series and many series throughout the world, that the results depend on a number of factors. And age and tumor size are one, and that cavernous sinus involvement. Some people feel that men respond better than women, but that's not a consistent finding. There was a recent study from China to suggest that. How much tumor we get out and how the hormone levels are before surgery. So if you have one criteria to define success, you can get one set of results. If you have a different criteria for success, you can get a different. So if they're using a different measuring stick, and you're comparing one center to another and saying, well, maybe I better go to this center, better know which measuring stick that they're using to define their cure rate. Okay, this is what I just said. You can see the tumor starting here a little bit, and then it grows off to the side, and then eventually it gets very big, which raises the issue about early diagnosis, that the earlier we can pick up these tumors, then the more chance we're going to cure them when they're small. I've told you a number of times that the cure rate depends on the size of the tumor and where it's growing. So imagine we get it here. The cure rate is going to be some of those numbers I showed you, 100%. If you go here, the cure rate is going to be much, much less. So this person is going to probably need medications for the rest of their life, and this one has one operation and they're done. So where does the person sit in this categories? That's what the skilled team and then the pathologist who looks at the tissue at how aggressive it's going needs to tell us. So just a word about gigantism. Gigantism is the same condition basically with excessive growth hormone, but it occurs before the bones have stopped growing. So in general, in younger people, they become extremely tall, and you've seen some pictures, and people develop extreme heights. And because it occurs at a young age, people who are young at that critical stage of development have different psychosocial and other effects that they have to deal with. So this is a special condition, not that when we're adults that we don't have issues like relationships, but at that age there are very special needs that this group of people have. So what about the surgery here? This is a study from one of my good friends in Japan, in Tokyo, where they have a big population, and they had 25 patients that they reported on less than 20 years. And this center does probably one of the most acromegaly surgeries in Asia and certainly in the world. And so over that many years, 13 years, they only had 25 patients. They probably had 1,500 patients with acromegaly, without gigantism. And they were almost evenly split between males and females. Average age was about 17. They had mutations, which are alterations in the DNA, in a much higher proportion. So not surprisingly, there was a genetic component to it. And people have looked at this. They tend to have bigger tumors. These tumors tend to be a bit more aggressive, and they can often produce different hormones. This is what plurihormonal means. So plurihormonal tumor in adults is much less common, but here it counted for 9. And because they were bigger and growing, they could only get a resection in under 70% of them. And I can tell you, this surgeon came to visit me very early in the 90s after we had started doing the procedure, and he does it very, very well. And even in his hands, they couldn't get the tumor out in at least 30 or more % of patients. And so they had remission in only about 50% of people with the surgery, and then if they added medication, about 3/4. So it's still 1/4 of people aren't under control. So this is a very difficult situation. I think these patients should have surgery in maybe one place in a country, or 2 at most, so that the experience and expertise can develop in those areas. So this raises the issue about early diagnosis. You heard me harping on this, and we're fortunate in Canada. We've developed a project. It'll go live after about 3 years of trying to get through all the privacy and ethics issues and computer issues. And this project, and maybe, I don't know if Deanna wants me to stop or to say a few words about this.
Stop, but I'm gonna make sure I slide you in
Okay.
sometime today or tomorrow to
Okay.
talk about, yeah.
Okay, so that's all I was going to say, that the point is it's critical to make the diagnosis early. And you are all critically important to that initiative, because you will make this study a success, and the people that you know with this condition. So that's all I want to say. I want to thank you for being here and taking your time to learn more about this condition and for having me.
Got it? You're gonna get
He's
the
gonna
video
play
up.
the video.
Oh, you got the video. Good. Okay.
You'll get it. I have total faith in you.
So while he's doing that, this study is going live on October the 20th. And all you do is click on that website, but there's those sheets on your desks that you can just take a picture of that.
Should Jill hand it out, the information for the research study that is gonna happen?
So make sure you grab one of these and take them home, because you need to,
Please participate.
participate, but you need to get a hold of the Acromegaly /research at SMHA.
No, you can go straight there. You don't have to, if you have questions, you can email us at acromegaly-research@SMH, which stands for St. Michael's Hospital.ca. If there are any questions, the person in charge of that is on her honeymoon now. Melissa is on her honeymoon, so that's why she'll be back by October 20th. That's why we're gonna start in October, and we were not starting today. So we were trying to start today, but she,
We're trying to launch
If we start in October, is it
it's gonna go on for as long as we can get, so we wanna get as many people. I'm aiming to try to get 1,000 people from Canada. If you can give it to 10 other people, and they don't all need to have acromegaly, they could have other kinds of tumors. And also we need a family member, first-degree blood relative, to get involved. To get ready, you need to get old pictures of yourself ready and some documents so that we know that you actually have acromegaly or what form. So how are we doing, Garnet?
It's giving me.
Okay. Okay, I think we have it working.
Iris requires a comprehensive knowledge of relevant surgical anatomy.
I'll just start it again. So we're gonna just show a cutaway of where the pituitary is first.
The endoscopic endonasal approach to cellular tumors that extend into the cavernous sinus requires a comprehensive knowledge of relevant surgical anatomy. These tumors are approached through the lateral space of the sphenoid sinus, contained within the body of the sphenoid bone. Understanding the anatomy of the region is critical to performing safe surgery for these tumors. The critical anatomical structures are the internal carotid artery, cranial nerves B1, 2, and 6, the optic system, and the pituitary gland. This presentation focuses on the pituitary tumors that grow into the cavernous sinus, encase the carotid artery, and displace the 6th cranial nerve laterally.
So this is the part that a nose specialist
The nasal
would do.
mucosa is prepared in a standard fashion. By removing the inferior half of the middle turbinates, a corridor through which instruments and the endoscope can maneuver is created bilaterally. A pedicled septal mucosa flap is elevated and placed into the nasal pharynx.
If it's a small tumor, we don't need to do that.
A posterior septostomy is performed to allow access to the site by either nasal passage. Next, the sphenoid rostrum is removed by expanding the natural ostia, or alternatively, by a direct midline route.
So now we're down into that sphenoid.
Prior to removing the sphenoid septa, the relation to the internal carotid arteries and optic nerves are carefully noted. The sphenoid mucosa is incised with the dissector. Alligator forceps grasp and free it from the bone, and it is kept in situ. As we enter the sphenoid, the sella turcica and the clivus are in the midline. Superiorly lie the optic nerves, and laterally the internal carotid arteries. The maxillary division of the trigeminal nerve can on occasion be seen more laterally. Tumor growth may cause distortion of these landmarks. The bone of the sellar floor is opened and elevated to expose the dura as laterally and superiorly as possible. A stellate incision is made in the dura. The dura is then carefully dissected from the tumor and expanding pituitary. The pseudoplane between the tumor and the pituitary gland is dissected with a round knife. The midline tumor is debulked using curettes and suction. The location of the internal carotid is determined by neuronavigation, Doppler ultrasound, and direct vision. The dura is then incised over the cavernous sinus. The tumor is removed from the cavernous sinus using a series of angled curettes and suction.
So it's a bit more complicated than that, but that, but that's called artistic license.
And covered by the sphenoid mucosa. This is then covered by a layer of fibrin glue. The pedicled septal mucosal flap fills the remainder of the sphenoid and is reinforced by another layer of fibrin glue. Scholastic nasal stents are sutured along the septum, and if necessary, nasal packing is applied. With the tumor successfully removed, the procedure is complete.
Okay, so that's, I wanted to show you that because it's an animation, and I think he did a nice job at helping to explain things. We use it for all our medical students and even our junior residents who are trying to understand the general concepts here. Obviously, the surgeons who operate in this area are going to go into much, much more detail. But as something to help people to understand, I think he did a nice job with it. So that's, if you want to look at it again, maybe write down that thing at the top there, that URL at the top. And we want people to use it and to look at it. Maybe we should put it onto YouTube. It might be easier to access there, but I think artists like this Vimeo website for some reason as opposed to YouTube, but certainly your organizations could, you guys could access that. So thanks for listening, and I think there's time for a break now, but I'm very happy to be with you, okay? So thank you for listening and having me.